When George asked me to give a few comments about psychotherapy outcome research, I confidently said, sure, no problem. It's 10 minutes long, piece of cake. By the way, I thought, oh shit, what can I say in 10 minutes that captures everything that the psychotherapy outcome research field has taught us? It's an impossible task in 10 minutes. So what I thought I'd do is just go over some highlights, general points, themes that have come up through the decades of psychotherapy outcome research, and not necessarily leave you with answers, but perhaps even scratching your head about what can we do next, questions that might stimulate discussion in the focus groups that we have this afternoon. Now, I will preface the rest of my very brief talk saying this is only the adult psychotherapy literature I'll talk about. I really don't know the child and youth literature well enough to give you some idea about what's going on. What we do know, there has been some recent work looking at the use of psychotherapy in Canada and finding that a large number of people use psychotherapy in any 1 year. The most recent data we have published in 2009 found that over 1 million Canadians used psychotherapy, engaged that service in the preceding year. That's pretty good. A lot of people availing themselves to what I'll tell you later is effective intervention. And the rates of psychotherapy use have been reasonably stable over the years, despite the fact that a trend that we're very well aware of is the increasing use of psychopharmacological medications for treating various mental disorders. And so despite that trend, we still see people engaging in psychotherapy at a reasonable rate. Now when it comes to the question, does psychotherapy work? It can be answered with the simple yes. How do we know? Well, we have decades of research that have been done with various types of treatments for various types of disorders. If we smush them all together in what are called meta-analyses, and now the new thing are mega-analyses. These are meta-analyses of meta-analyses, trying to bring together some semblance of coherence from a very large literature and say, okay, over the course of all these studies, what is the ultimate effect for psychotherapy? And generally what we find is an effect size of 0.8, which means that approximately 80% of people who engage in psychotherapeutic services are going to do better than those who do not engage such services. It's a large effect, and in fact some people have posed the questions, well, the effect of psychotherapy, okay, it's 0.8, what does this really mean? Relative to other types of health interventions, is it a powerful effect? Is it strong? And people have looked at the effect of psychotherapy relative to some other effects for common mental or medical interventions, and in fact found that psychotherapy is one of the more powerful interventions. One of the metrics that are used to address this issue is numbers needed to treat. So how many patients do you need to treat with a particular intervention to avoid one case? Well, it's a hard answer to come up with, because if we say, psychotherapy, treat what? Well, there's lots of different disorders, lots of different types of therapy. But in general, the numbers needed to treat, people have found from 3 to 5, which is very, very low, meaning very powerful effect, whereas some others, say for, I can't remember the one that I looked up very quickly to look at, the statins, it's over 100. So psychotherapy is a powerful intervention. Another question that comes up is the cost effectiveness of psychotherapy. It is an expensive intervention, but is it a cost-effective intervention? Now, if we look at some of the points to kind of situate this question, we find that about 20% of Canadians will directly The remaining 4 will be affected in some way by it, either having a child, a spouse, close friend, partner at work. It affects a lot of people. It's the second leading cause of disability in Canada. And a number that's come up, and it's come up a lot, $51 billion associated with mental health and disability in our economy. That's massive. Looking at depression, which is most commonly talked about, lifetime incidence of major depression in Canada is 8.6%. Very high. So people have started to look at, well, if we offer psychotherapy, does it work? And is it also cost effective? So cost effective outcomes, there's a variety of them. You see quality adjusted life years gained. So people's quality of life improves. Decreased disability, more able to do things. Decreased days spent in hospital. We know a lot of people who come to see us will engage emergency services, inpatient services, so their access, or not necessarily their access, but their engagement of those services goes down. And there's also some evidence of cost offset, so that we see decreased use of medication and other types of healthcare costs. So although it may be an expensive intervention to provide, we may actually be gaining by patients not utilizing other expensive health services. The relative efficacy of psychotherapy approaches. First point I put here, this is a highly contentious and divisive issue. Does my treatment work better than yours? That's the basic question. And it's a reasonable question. Which treatment works best? And I wish I could give you a very clear answer, but there is no clear answer. At the most general level, there's not much indication that any one treatment for any one disorder is better than another. There's lots of meta-analyses out there that say, yeah, a lot of these so-called bona fide treatments, so the treatments that have been studied, a fair bit, very well developed, they all seem to work generally about equally as well. But really, do we gain anything from asking that generic of a question? Does treatment A work better than B? Without contextualizing it. So people have moved toward providing some context for that question. In this kind of circumstance, say for this particular disorder, which treatments do you know are effective? Not necessarily engaging in this brand competition, but we want to know what works. And we can say that there is a growing body of evidence that a variety of treatments are effective for a variety of types of disorders. And so for I'll get back to major depression. It's the one disorder that's received the lion's share of attention in the research literature. We can say quite confidently that there are a number of effective treatments out there. So at a clinical level, we ought to feel some comfort in knowing that there are some effective interventions. Now, to get into the debate about which works better and provided by whom and when and so forth, that may be beyond what a practice research network can really help us with, but it does provide us with a foundation. Psychotherapy and medications, I'll just focus on antidepressant use because that's the one that's been studied the most. We find therapy and use of SSRIs, which are the most common antidepressants used, more effective than placebo. So that's good. Not to be dismissive of the effectiveness, it's very surprising how well it works. Psychotherapy and SSRIs have little differences in their effectiveness. There are some situations where one is better than the other, but we find that overall they work very well, each of them. We have found that longer-term outcomes tend to be more enhanced when people receive psychotherapy. And we've also found that dropping out of treatment seems to be lower when people receive psychotherapy rather than just medications alone. Now, I can't provide much of a summary, but a basic summary, again, a foundation for us to work with, is that overall there is strong evidence for the efficacy of psychological therapies. Patients can achieve symptom reduction and sometimes freedom from symptoms. There are other outcomes that are favorably affected, such as social functioning, work functioning, interpersonal relationships, quality of life. They shouldn't be dismissed, and it could be argued that these are perhaps even more important than just symptoms. Psychotherapy is cost-effective in improving quality of life years. Your life gets better. People have a sense that their life is better. They want to live longer. There's evidence of cost offset. And for many disorders, there's evidence that there are a multitude of treatments that have been found to be reliably effective. There are some commonly used psychotherapies, like psychodynamic therapy, that are simply less researched than others. By far, the most evidence is for CBT. It's the one that's been studied the most. And this absence of evidence limits the scope and strength of the statements we can say about efficacious treatment. So just because a treatment hasn't been studied much does not mean that it's less effective. It just hasn't been studied as much. We know less about it. Group therapy. It's important to point out that in most studies that have looked at the effect of group and individual therapy, they have found little difference of effectiveness between these two approaches to treatment. And group therapy is often seen as the more efficient approach to treatment. That being said, our database is much, much smaller for group therapy relative to the individual therapy literature. It's just harder to do group therapy research. It's tough, but there are a number of people out there doing it. And there are also some practical resistances that people have to doing group therapy as a clinical intervention and also group therapy research. Since loss of individuality, privacy issues, it's a lot harder to construct a group and to run a research study around that as well. Long-term therapy. This is something that often comes up in discussions of what's empirically supported. It's virtually impossible to do randomized controlled trials on long-term therapy. You're not going to get funded for it, at least in North America. It's even difficult to do that in Europe as well, where it's a much more vibrant part of the health delivery system. So we have to rely on other methodologies for finding out how well it works. And fortunately, a lot of people have undertaken this task. And in fact, 2 recent meta-analytic reviews that involved collectively over 5,000 patients has provided some pretty convincing evidence for the effectiveness of long-term therapy. It's hard to dismiss evidence from that size of a sample. But we have a lot of questions. I hope you have a lot of questions about it. Often, our studies are very clean, and it leaves a lot of questions. When people say, well, yes, I understand this RCT found treatment A to work, but what about in the clinical reality where I am? And often we're talking about issues of diversity, this refers to ethnicity, gender, sexual orientation, disability status, comorbidities, of course. How well do these treatments work in these contexts? What treatment outcomes should be examined? We often rely on patient self-report by and large. Sometimes we also rely on external observer ratings. But which should a particular perspective of outcome be privileged, or should we have multitudes of outcomes looked at? Is self-report, objective behavioral indices, therapist judgment, cost? What about the short-term versus long-term? Does manualization improve therapy outcomes? To get funded for an RCT, you have to have a treatment manual. You use that treatment manual to train the therapist delivering the study interventions. And so it works well in that context, but it doesn't necessarily enhance treatment outcomes where it really matters where you work. We really don't know. And ultimately, when we're studying a particular treatment, we're studying a treatment package, something that's put together nice and coherently, and it's delivered. And we may find that it works, and it works really well. But then we ask ourselves, well, what part worked? There's a lot of what we think are really specific interventions, powerful interventions, because it took us a long time to think of them. But which part works? There's not a lot of research that has looked at this, but it's important. And this is where we often come and discover commonalities. Things that we may find are very specific and unique to our particular intervention, in fact, are very common with others. This is how we get at it. And so, another question is, which treatment elements predict successful outcomes? We need to look at that. And as we get into these more particular questions, we move beyond just basic outcome research, and we start inviting questions that many of which Louis talked about in his presentation. I don't believe you touched on anything related to just generic outcome. There's very specific questions about what's done during the course of treatment that's going to influence outcome. And that's what the next presentation is about. And I think that's what you'll find very engaging and will stimulate even more ideas as we break into our task group later this afternoon. Thanks.